Hello, everyone. It's a great pleasure to stay with you again. So today, I want to talk to you about the three different things and try to join these topics. So I want to to talk about endometriosis, infertility, and laparoscopic. So in this way, the first question that we have is operate on any patient with reproductive desire and suspicion or diagnosis of endometriosis. In this way, we need to remember what is the different classification of endometriosis to try to understand what is the management of endometriosis associated with infertility. So we need to remember that the endometriosis is a presence of endometrial-like tissue outside the uterine cavity, endometrial gland, and stroma. Endometriosis is a challenging condition for women of reproductive age, causing problems such as infertility and chronic pelvic pain. It's a complex syndrome characterized by a chronic estrogen-dependent inflammatory process. The endometriosis represents 10% of the women of reproductive age, and it represents 200 million women in the world. It represents 20 to 5 women with infertility have endometriosis, and they complain in chronic pelvic pain. The percentage rise until 80%. So determining prevalence in the general population is challenging because some women are asymptomatic and those with symptoms may have varied or non-specific presentation. So remember, a lot of patients that want to use a contraceptive pills. So the contraceptive pills, it's a way to try to bring the pain in the patient with endometriosis. So it's possible that the diagnosis will be delayed. We need to remember the different classifications. So today I will talk about two classifications from the American Society for Reproductive Medicine and the AFE. In the AFE, it's endometriosis fertility index. So we need to remember this. This is a classical classification. You can see at the top the classification of endometriosis, the endometriosis lesion according to the endometriosis lesion. At the bottom, you can see classification according to additional lesion. So when you stratify the endometriosis in the surgery, you can define the endometriosis in stage 1, stage 2, stage 3, or stage 4, depends on the point that you are seeing in the different points. It's very important to understand the first classification because you need to use this classification in the endometriosis fertility index. The EFI, the objective of EFI, is predict the chance of pregnancy in fertile women with endometriosis after established surgery. So if we have an EFI score low, for example, 0 to 3, in this case, it's associated with a cumulative pregnancy rate and spontaneous conception of 10% after 3 years. But, for example, you have high EFIs in absence of other facts, the infertility seems to have a good prognosis for spontaneous conception or for the use of YY. So the EFI is very important to try to define if the patient is allowed to get a pregnancy in normal way, or is better to give the patient to another treatment of reproductive assist. So the endometriosis fertility index is this. You can see in the left side historical factors include age, years infertile, prior pregnancy, and this is the total score here. And in the right side, you can see surgical factors. So you can see there that the endometriosis is scored by endometriosis lesion, and this point is the endometriosis of the total score in the ASRM classification. You need to use a last function score. Last function score is to define so the function of the fallopian tube, fimbria, and ovary. The function is normal, mild dysfunction, moderate dysfunction, severe dysfunction, or if the structure is absent or not functional. You point here and you sum the historical factor and surgical factors, and you can get the F score. So if you have low F score, in the case, for example, 0 to 3, the probability to get pregnant, to achieve end of pregnant in 36 months is less than 10%. But if you have F score, high F score, more than 7, 8, or 9, 10 F score, the probability to achieve it to pregnant is really high, is more than 15%. But the real problem is when you have an intermediate score. What can I do in this case? So in this case, it's very important to try to understand what is the symptoms of the patient, what is the desire of the patient, if there are another factor, not male factor, female factor, to try to understand what is the best way to recommend the patients. And what is the surgical treatment of endometriosis associated with infertility? So you know the laparotomy, laparoscopic, and robotic surgery are the options. But you know that the gynecologists are worldwide decide to use laparoscopic. So you know what is the great advantage. So the surgical intervention aims is to remove endometriotic implants and endometriomas and restore normal pelvic anatomy to the greatest extent possible. It's different way to approach the problem. So, for example, the studies have shown that laparoscopic surgery in minimal and mild endometriosis improve fertility and IVF rates. In moderate to severe endometriosis, laparoscopic surgery can treat pelvic adhesion, but there are not enough randomized control trials on postoperative pregnancy rates. For ovarian endophthalmomas larger than 3 to 4 centimeters, excision surgery has shown better results than ablation or drainage with respect to spontaneous pregnancy rate in women with previous infertility. I will talk about the different topics in the next slide. So in the case of endometriosis 1 and 2, so there are a lot of studies to try to explain what is better. So this classical study from the Canadian group in head of Dr. Mark Cooks, published in 1997, compare laparoscopic surgery and diagnosis laparoscopy in the case of 1 and 2, endometriosis 1 and 2. 172 patients in the group of laparoscopic surgery and 169 in the diagnosis laparoscopy. So the results are, if you see here, the pregnancy, the cumulative probability of a pregnancy of more than 20 weeks is higher when you decide to use a laparoscopic surgery, is 30%. But if you decide only do a diagnosis laparoscopy, the cumulative probability of a pregnancy of more than 20 weeks is really low, is less than 20. So the intraoperative complication is the same in the group of laparoscopic surgery and diagnosis laparoscopy. In conclusion of this study is laparoscopic surgery in infertile women with minimal or mild endometriosis is effective in increasing their fecundity while involving minimal risk. But 2 years later, appeared this study for the Italian group in head of Dr. Fabio Parassini that considered 51 women in the resection ablation. Another group was 45 in untreated group, so in diagnostic laparoscopy, that completed the follow-up period until 12 months. 24% in the group of resection ablation group become pregnant, and 29% in the untreated group become pregnant. So the result is contrary to what was found in Mark Cox in 1997 study, but the difference was not really significant. In the next years, in 2007, this study from the French group, it's about reproductive outcomes after laparoscopic treatment and endometriosis in an infertile population. This is a retrospective analysis for 34 patients who had more than 1 year of infertility and desire for pregnancy associated with minimal to severe endometriosis lesion. So in this case, include the patient between 1 and 4 endometriosis. After the intervention, the patient was followed in consultation every 3 months for 1 year and then every 6 months. This study showed us that the 86.5% of pregnancy ended in labor as a result. 60% of the pregnancies obtained were spontaneous with a median time of 5 months. Among pregnant patients with stage 1 and 2, The median time to spontaneous pregnancy was 2 months and 20.5 months after ART. The achieved pregnancy was 89% when you assume the patient that decided to spontaneous pregnancy plus patient that did an ART. For pregnant patients with stage 3 and 4, the median time to spontaneous pregnancy was 8 months and 12 months after ART. Achieved pregnancy in sum, but it was 56%. In conclusion of this study, in the case of stage 1 and 2 endometriosis, spontaneous pregnancy should be attempted after surgery for 8 to 12 months before switching to ART. In the case of stage 3 and 4 endometriosis, ART should be indicated after 6 to 6 months of the surgical procedure. But remember, it's very important to understand another factors like age, another factor like the size of the patient or the couple, the other factors, infertility in men or female, etc. This publication for the Taiwanese group in 2014 is a meta-analysis about laparoscopic surgery for fertility related to endometriosis. So in this study was included 6 studies. Two of them was a randomized studies, and the 4 it's a non-randomized studies. 4 studies was minimal and mild, and 2 studies was moderate, and only 1 to severe. So the conclusion of this study about the surgery was that 1.4 times more times is better than laparoscopic surgery when was compared with the diagnostic surgery in the randomized studies. In the case of non-randomized study, was 1.5 more cases of pregnancy when compared with diagnosis laparoscopy. In total, 1.4 times is better. Statistics suggest that the therapeutic laparoscopic surgery improves pregnancy rates in subfertile women with endometriosis compared to controls, including diagnostic laparoscopic only, danazol treatment, and laparotomy. About the complication, it was the same real, so it 1.8 more times, but really crosses the 1, but it's not statistically significant. This study tell us that the meta-analysis of this review demonstrated a statistically significant benefits of laparoscopic surgery in improving pregnancy rates in women with endometriosis. This benefit was demonstrated primarily in women whose infertility was primarily caused by minimal and mild endometriosis. There was only 1 study investigating surgical treatment for advanced endometriosis, but the results were affected by confunders. And non-statistical differences were found in terms of complication with therapeutic versus laparoscopic diagnosis. Despite the remarkable heterogeneity among the included studies, most studies demonstrated consistent benefits of surgical laparoscopy infertility results. This meta-analysis, a systematic review for the Australian group about intervention for endometriosis-related infertility, was published in 2020, include 26 FTC, include 2,245 women with related infertility with endometriosis. This meta-analysis showed that compared to placebo and other therapies, the surgical laparoscopy alone had 1.6 more times to get pregnant, and GnRH agonist alone is 1.6 more times. So the result is increased chance of pregnancy to do a surgical laparoscopy. This Cochrane publication about laparoscopic surgery in 2020, your objective was to assess the effectiveness and safety of laparoscopic surgery in the treatment of pain and infertility associated with minimal to severe endometriosis, including 14 RCTs. The study randomized 1,563 women with endometriosis. And this study compares a lot of different situations. For example, compare laparoscopic ablation or excision versus diagnosis only. Compare laparoscopic excision versus diagnostic laparoscopy alone. Compare laparoscopic ablation and uterine nerve transection with diagnosis laparoscopic alone. Compare laparoscopic ablation versus laparoscopic excision. compare laparoscopic ablation with diagnostic laparoscopy and use of a generation analogous, compare laparoscopic ablation or excision with alien thermal coagulator or electrodiathermy, compare laparoscopic ablation or excision with laparoscopic ablation or excision and uterine suspension, compare conservative laparoscopy surgery with laparoscopic colorectal resection of deep infiltrated endometriosis. So it's a lot of comparisons, but the conclusion in this case is there is moderate quality evidence that therapeutic laparoscopic surgery increases the rate of viable intrauterine pregnancies confirmed by ultrasound compared with diagnostic laparoscopy alone. It's 1.8 more times. Further research is needed that looks at the treatment of different subtypes of endometriosis and that compares laparoscopic intervention with lifestyle and medical interventions. So the guideline of the European Society of Human Reproduction and Embryology that was published in 2022 recommend us that the operative laparoscopy could be offered as a treatment option for endometriosis associated infertility in cases of stage 1 and stage 2 endometriosis, as it improves the rate of ongoing pregnancy. So it's very different when we talk about endometriosis 3 and 4, because only a minority of surgical studies on deep endometriosis report postoperative pregnancy rates. Studies conducted are low quality, but these are suboptimal studies. The group is heterogeneous and without the possibility of generalizing conclusions. But we have a lot of publication about this. This is the study published by Dr. Paolo Bersellini in 2012 about the effect of patient selection on estimate of reproductive success after surgery for rectovaginal endometriosis. It's a systematic review of the literature. They identified 11 studies published between 2005 and 2011 that assess reproductive performance after surgery for rectovaginal and rectosigmoid endometriosis. So the percentage of the pregnant women independently of preoperative fertility status and performance of ABA previously. So the conclusion across the group of 551 women with desire of pregnancy after surgery, 223 conceptions were observed, with pregnancy rate ranging between 19 to 17%, with an age mean of 39% at 36-month follow-up. So the percentage of spontaneous conception in fertile women at the end of the follow-up was only 123 pregnancies were reported among the 510 infertile patients who saw a spontaneous pregnancy. It's between 10 to 41%, with a weighted mean 24% at 36 months follow-up. Overall, one in 4 infertile women who underwent a radical surgery finally achieved a spontaneous pregnancy. However, by low quality of the study, the problem is the overestimation of the good prognosis of these patients. This publication in 2014, it's about fertility before and after surgery for deep infiltrated endometriosis with and without bowel involvement. It's a literature review. So the aim of this review was to assess the impact of various deep infiltrated endometriosis locations on spontaneous fertility and the benefits of surgery and medical assisted reproduction, ART, infertility outcomes. So include a article published between 1990 and to 2013 among women with deep infiltrated endometriosis and without intestinal involvement. No preoperative data were available on spontaneous pregnancy rate. That the rate of postoperative spontaneous pregnancy rate in these women was 50%, and the overall means the sum of the spontaneous pregnant plus ART. In this case, was 62%. Women with deep infiltrated endometriosis and intestinal involvement was 1,436. It was not feasible to assess fertility outcome based on deep infiltrated endometriosis location. But for women with deep infiltrated endometriosis with intestinal involvement without surgical management, the pregnancy rate after ART was 29%. For those with intestinal involvement that was surgical management, postoperative spontaneous pregnancy rate was 28%. It's very similar. And overall, postoperative pregnancy rate was 46%. So it's important to understand that the overall is the sum of the spontaneous plus ART. For women with deep infiltrated endometriosis without intestinal involvement, surgery alone offers a high spontaneous pregnancy rate. For those with intestinal involvement, spontaneous pregnancy rate is low and relatively high when combined with ART, suggesting the potential benefit of combining surgery and ART in case of deep infiltrated endometriosis. This article is about endometriosis fertility indices to predict live births following surgical resection in case of endometriosis 3 and 4. So we can see in this plot that the cumulative incidence of pregnancy in non-ART live births in the bottom, overall live births, and the next slide is in ART live births. So I need to explain. For example, if you have FE score low, the probability to achieve or pregnant is 0 in 5 years. But in the case of FE score is high, 7, 8, 9, or 10, the probability to achieving pregnancy is 91%. When you sum the ART plus spontaneous conception, you can see in the FE score, in low FE score, the probability to achieving a pregnant is 39 in the second year. So this explains us that it's very important to try to explain the patient that if he have endometriosis with FE score low, it's better to proceed to an ART. So in the case of FE high FE score, so the probability is very similar in overall when we decide to use ART is the same to the non-ART live births. So in this plot, we can see the ART live births. So the percentage is really high when in the case of FE score low. And if you can see the FE score high, 9, 10, the probability to get a live birth is 71. So when we high FE have an excellent fertility prognosis after endometriosis 3 and 4 surgery, and may be advised to try to get pregnant spontaneously. Or like for women with a low FE score, it's more reasonable to refer to ART. Other prognostic factors may be used to guide the treatment of women with an intermediate FE score. For example, it's important to understand the symptoms, the age, insufficient previous surgery, ovarian reserve, and other factors like male or female factors for infertility. This publication in 2022 about the high spontaneous pregnancy and live birth rate in patients with stage 3 and 4 endometriosis following surgical management. It's a retrospective study of 109 women who underwent laparoscopy between 2018 and to September 2020. 57 patients become pregnant spontaneous after surgery. 53 become pregnant within a year of surgery. Patients with bilateral cystectomy achieved a spontaneous pregnancy rate of 42%. The patient with very low anti-mullerian hormone and unilateral cystectomy achieved a high spontaneous pregnancy rate of 60%. The live birth rate was 76, with the miscarriage rate being 8.5 and the ectopic pregnancy rate being 4.8%. The FE score was a significant prognostic factor for spontaneous pregnancy and live birth outcomes. So this plot will explain the same. If you have a FE score high, the pregnancy rate is high. If you have a FE score low, the pregnancy rate after 25 months is low. The live birth is the same. The guideline of European Society of Human Reproduction, published in 2020, recommend us, although no compelling evidence exists that operative laparoscopy for deep endometriosis improves fertility, operative laparoscopy may represent a treatment option in symptomatic patients wishing to conceive. The GDG recommends that the decision to perform surgery should be guided by the presence or absence of pain symptoms, patient age or preference, history of previous surgery, presence of other infertility factors, ovarian reserve, and estimate epi. In the case of endometriomas, there are no specific RCT comparing fertility outcomes after endometrioma surgery compared to expectant management, nor studies that explore the indication of surgery according to the size of cyst, and the selection of patients according to other criteria become relevant. Associated pain, size of the endometrioma, difficulty in performing ART in the time that we decide to pick up the oocytes. This study, this meta-analysis and randomized control trials, compare laparoscopic ovarian cystectomy versus fenestration, coagulation, or less evaporation. This includes 7 articles that the recurrence of signs and symptoms, the recurrence of endometriomas, and the pregnancy rates. In this plot, we can see that the cystectomy is better than the fenestration of coagulation in reduce the recurrence of signs and symptoms. In this plot, we can see that the recurrence of endometrioma is less in the case of cystectomy versus fenestration or coagulation. So laparoscopic cystectomy decreases the recurrence of endometrioma associated symptoms, as well as the recurrence of endometriomas. And in this plot, we can see the laparoscopic cystectomy increases pregnancy rates compared to fenestration, coagulation, and laser ablation is 2 times more. This endometriosis guideline from French is about the surgical management of endometriomas, different alternatives in terms of pain, fertility, and recurrence. The conclusion in these guidelines of French is ovarian cystectomy leads in the short times to a significant reduction in the level of AMH, as well as reduction in the number of antral follicles in the affected ovary. This phenomenon is greater in the case of bilateral cystectomy or in the case of large cysts. Laparoscopic cystectomy improves spontaneous pregnancy rates in infertile women compared to drainage clotting. Laparoscopic cystectomy offers no advantage in ABF pregnancy rate compared to less evaporization or expectant management. In the context of ABA treatment, simple ultrasound-guided endometrioma puncture has been sufficiently studied to establish recommendation. So it's very important to show it's a good patients. Symptoms, cyst size, ovarian reserve, and ECO puncture. This systematic review meta-analysis about the success of adjuvant endometrioma treatment in infertility include 8 studies, 553 women, and compare a different groups: surgeries plus ART, surgery, only surgery, aspiration plus ART, and only ART. So you can see the pregnancy rate is very similar in all groups. It's 38% surgery plus ART, 43% in surgeries, aspiration plus ART 39%, ART only is 29%. But the important result here is to understand what the patient wish, what the couple wish, because the duration of follow-up to achievement of pregnancy is 1 to 2 cycles in the case that you decide to use ART, and ART. But if you decide only to wait the surgery, do your effect is until 2 years. So it's very important to understand what is the desire of the patient, of the couples. The guideline of the European Society of Human Reproduction and Embryology tell us about clinicians may consider operative laparoscopy for the treatment of endometrioma associated infertility, as it may increase the chance of natural pregnancy, although no data from comparative studies exist. Clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART to improve IVF rates, as the current evidence shows no benefits, and surgery is likely to have a negative impact on ovarian reserve. And surgery for endometrioma prior to ART can be considered to improve endometriosis associated pain or accessibility of follicles when they pick up oocytes. And what about ART and endometriosis? So if you have endometriosis 1 or 2, the IUI is a good selection to explain the patient can more quickly you're pregnant if decide after the surgery, try IUI. But in the case of the endometriosis 3 or 4, the best option is ABF because the IUI is not really very good idea. So the final message is classify with ASRM and EPI score. In suspected endometriosis 1 and 2, diagnosis surgical laparoscopic increases the chances of spontaneous conception. In suspected endometriosis 3 and 4, and deep infiltrated endometriosis, and in case of endometriomas, surgical laparoscopic may be an option in selected patients. In endometriosis 1 and 2, the use of postoperative intrauterine artificial insemination increases pregnancy rate when compared with expectant management. In endometriosis 3 and 4, the use of postoperative in vitro fertilization increases pregnancy rate compared to expectant management. Always keep in mind before the surgical decision, age of the patient, ovarian reserve, presence of other infertility factors in women, presence of associated male infertility factor, previous surgery for endometriosis, infertility time, risk of surgical complication, patient partner preference, presence of neuropain, FE score. And finally, surgical laparoscopic and assisted reproduction treatment are not mutually exclusive, but rather complementary and represent efficient alternatives for the treatment of infertility associated with endometriosis. So that's all. I have very happy because the time that I share with you, and I hope to see you again soon. Bye bye.